So if I were to have a patient enter the hospital that is ready for surgery, they usually would show up in the morning, and our reception team would start taking care of the initial forms. The forms that we always start out with are consent forms. As a primarily paperless hospital, we have everything on our computer except a couple of things. So when the patient gets here, for example, I'm going to use Sunny here as an example. When our patient gets here, they sign a consent form advising the owner about anything that we are going to do in today. So we go over that, we confirm with the owner that we're going to do, for example, this was a gallbladder surgery, that we are aware that this is a major abdominal surgery, if we're going to do any blood work or if we need any biopsies for things like that, if they're on any medications, the strength and how much they get, as well as if they gave it that morning as well, if it's something that we have to look out for. For patients that, for example, have heart conditions, we need to know if they've gotten their medications previously. We may adjust their pre-medications based off of that. The other most important thing about this consent form is their CPR code. So we go over with the owner that in the event that our patient has a cardiac or pulmonary event or episode, there are associated fees with that. We will try our best to get them back, but there are still associated fees. Would you like us to perform CPR on your patient or on your pet? I feel owners either, they either say yes or no. There's no wrong answer. So in our case, we did yes for CPR. So we have them sign that they are aware of the initial charges, that people, that we will always try to reach them as much as we can while we're performing CPR. And then we have them sign it. Because it's electronically, we have them electronically sign stuff. So that's all there. So once their consent is filled out, they are checked into the hospital, and when we check them into the hospital, we actually print out a form, and this form is for us to just kind of have in treatment with us, so that we can just keep track of all of our surgeries, and sometimes it's a little bit easier to visualize stuff when it's not on the computer. So this goes over our entire patient history. So it's Sunny, he's an 11-year-old neutered male Bichon. He's getting a gallbladder surgery today. It also goes over the, kind of the owner's information. It has his previous weights on here. It has his vaccine history. It also goes over kind of more information. So he had abdominal x-rays recently. He had chest x-rays recently. We also got an ultrasound on him. So this is just kind of a brief look into what we've done recently with him. But it doesn't give us everything. It doesn't tell us if we had any blood work or anything recently. So for that, we're going to have to go into his chart. Now, because everything is electronic, it is very easy to go and look in his chart for his labs and look at the blood work that he had run recently. Also, I can look for any previous medical history that was in here if we've never seen the patient before. In this case, we've seen this patient many times throughout the year, so we know much about him. We also have in here a couple of things scanned in. So we have cardiology reports scanned in, we have ultrasound reports scanned in, and those are all itemized so that if a doctor is looking for it, they can just kind of find it very fast, so that they don't have to search very hard for it, because that's probably the worst part about not having, a practice that deals a lot with folders and papers, is that you kind of have to go through stuff. So having a primarily paperless practice, it's a lot easier to find our things. Once the patient comes back here, and we make sure that everything is signed, we put him in a cage, and we want to make sure that we know who he is. So he gets a little cage card with all of his information on it. So his name, his breed, what type of dog he is, what color he is, because we can have multiple types of Bichons or Yorkies, or Doodles. The surgery that he's getting, the date that he's in, as well as a very easily spotted sticker, which can either be green or red, and this is just a fast indication for us so that we don't have to go looking in his chart if he were to have a cardiac episode, if we can perform CPR. So we always just have that kind of right there in our face, so we know, yes, he's for CPR, no, he's not, so we just don't have to go searching for his consent. It's not hard to find his consent, but if we can get to performing the CPR faster, then it will help our patient. The other thing that we have that is paperless are our anesthesia forms. So when the doctor is writing up his surgery report, because we're not writing everything down with our anesthesia, we have it saved so that we can put it right on his surgery report. This will monitor our anesthesia, our ECG, our trends, our blood pressure. So we have that right on the surgery report for the doctor to go back at and make sure that everything ran smoothly, if there are any complications after surgery, just in case he's curious about what was going on. Laboratory forms, like I said previously, are usually any blood work that we've run in-house, any blood work that we've sent to the lab, we have right on hand here in this tab. And then finally, once the surgery is completed and we send our patient home, when the patient is here, we always have a treatment sheet on hand listing everything that he was to get. So open his treatment sheet, and this goes over all of, if any, medications that they need in the day, their fluid rate, their basic vitals, so their TPR, their mucous membranes, their mentation, before and after surgery. For example, he was getting a number of different medications, so we wanted to make sure that he was all written down, whether or not it was once a day, twice a day, who's given it, what time they gave it, and the dose, whether or not we have to check his fluid rate, are we raising it, are we lowering it. So these are all forms that we mark here that we keep for a number of days as the patient stays in the hospital. Once the patient leaves, we finalize the report and mark that they went home. Once they go home, we talk to the owner about the surgery that actually happened. So we tell them, or the doctor will discharge the patient, and excuse me, I'm sorry. The doctor will discharge the patient, and we will reiterate to the owner any medications that they're going home with. So we write usually everything down as easily understood as we can. So for this pet was given oral antibiotics sent home, oral anti-inflammatory sent home, as well as a fentanyl patch placed. We place a fentanyl patch, we show her, we write on our discharge what leg it was placed on, we show her what the color bandage is, we let her know what day to come back so that we can remove it. And then we also write down exactly the medications that they're to go home with, how much to give, when to give it, when they should start it. If we had admitted it that day, then you start tomorrow. If it's once a day medication or if it's twice a day medication. I also like to go over with the owners some of the side effects that can happen. So if when you're on a bunch of different antibiotics, you can have some GI upset, especially after getting an abdominal surgery. A lot of times patients don't want to eat, so we send them home with a little appetite stimulant. The fentanyl patch itself can curb the appetite, so that's another use of the appetite stimulant. The fentanyl patch can also hinder GI movement, so sometimes they don't defecate, and owners get a little worried that after the surgery they haven't defecated a lot. So these are all things that we just go over with the owner. We also let them know if they're on any anti-inflammatory medications, what to look out for, which can also cause GI upset. If they've been sent home with a steroid, to look out for any increased thirst and urination, and that these are very common side effects that they don't have to worry, but if they want to call us, they absolutely can. And usually the last question that owners ask is if they can give all of these medications at once. Depending on the types of medications, I feel like the answer is usually yes. If the owner does wish to kind of separate them a little bit, as long as the patient is doing well, then we always say, do as you can at home as long as the patient is doing well. If it is a number of medications, if it's a pain medication mixed with an antibiotic, then we say if it's easier to give it at once, then do that. Yes, so that is kind of our intake to discharge of our surgical patients here at our hospital. We're going to get ready to take Katie out of her cage. We're going to set her up over there, demonstrate some things. So Katie is ready to come out. Hi. I'm just going to scoop her up because I don't want to, dachshunds, they sometimes can hurt their back, so I don't want to hurt their back, so I have her scooped here. Come on. So the first thing I'm going to demonstrate is how to put on a dog muzzle. The safest way to do this is to have two people that are communicating with each other. So if we were to put Katie in a headlock, but we'll do that kind of a quick, there we go, and then just kind of very fast place that on her, kind of before she knows that it's coming, because sometimes even the approach can scare the patient. And then I'm just going to tighten it here. And now it's all buckled. Oh no. So that is how we put on dog muzzles. The next thing is applying an e-collar. So you want to make sure that e-collars are the appropriate size and length, depending on where their incision is, or if there was an IV catheter placement. So if, for example, if she had an IV catheter placed, I would want to make sure that the e-collar is long enough for her nose that she wouldn't be able to get out and get to her arm to bite at her collar, but I would want it to be tight enough that she wouldn't be able to paw it off. So put this on the tightest one here. In and out, and then we can put this around her collar. And this would be a little long for her if she would have a catheter, but it would be appropriate size for if she would have to have an abdominal incision. The last thing I'm going to demonstrate is just how to hold a patient for blood draw. So I'm actually just going to take over. Okay, so for blood draw, there's 3 different methods of blood draw. We can take from the jugular vein, the cephalic vein, or the saphenous vein. So if I were to hold her for a jugular blood draw, I would have her try to sit. In this case, sitting might not be as helpful. So I would hold her head straight up as much as she can, so that whoever is drawing the blood can get it from either this side here or this side here. And I would try to keep her body as still as possible. I would talk to her, try to have her pay attention to me, while still remaining safe because my fingers are close to her face, so if at times we do have to place a muzzle, as long as everyone's safe. For a cephalic blood draw, I would have her kind of in this hold here, so my arm is wrapped around her neck, but not pushing against her neck. And I would take my right arm here and hold out this arm. My right hand is behind her elbow and I'm pushing it out. And at the same time, I'm using my thumb to occlude the vein and kind of give it a little roll there. That way whoever is taking the blood can see it as well. And I have full control of her head here, so she can't kind of go down and if she were to get nervous and try to bite. The last way, if I were to use the cephalic vein, which would be this hind leg here, I would have her standing on all fours, and I would kind of be supporting her with my arm here, but also going back here. If the vein were to run in this direction and go behind, I would be occluding the vein with my right hand, a couple of my fingers, and just kind of holding off, but still supporting her body so she doesn't kind of fall down.
So yeah, Katie's wonderful. Thank you.
And now we'll put her back in her cage. So again, I'm trying to, hold her as well as I can, making sure she's comfortable. When we put patients back, we want to make sure they don't turn around and dive back at us, so there's always a hand on us. And we carefully close the cage, make sure we don't get any toes stuck. But she's a good patient. Katie is going to help me demonstrate how to perform a pre-anesthetic or physical exam on a canine. So Katie is a 15-year-old dachshund. She does have a history of having heart disease. So we're going to make sure we definitely pay attention there. Starting our exam, looking at her face. Hello. Hi, I see that she doesn't have any redness or any swelling by her eyes. She may have some lens changes here on her eyes, perhaps very mild, but her pupils are responding normally.
I see your teeth. Oh.
Definitely some dental disease, lots of tartar on those teeth, and some halitosis, some really bad breath. Her ears look good. There's no redness or any obvious inflammation. And inside the canal looks pretty clean. I'm also making sure that her lymph nodes feel nice and small, or if I can feel them at all. Making sure. Being a dachshund, they're prone to spinal injuries, so you know, we can palpate her back, make sure that she doesn't have any obvious pain there. Also feel for her other lymph nodes. Not large. See if we can feel these a little bit better. Her coat looks good. Her fur is in order. We'll start by listening to her chest. So she, upon assaulting her heart, she definitely has a heart murmur, probably somewhere around a 3 or a 4. It is quite loud, but it is hard to pinpoint exactly where it is. Now the fact that she has a heart murmur, listening to her chest, I'm making sure I don't hear any abnormal sounds. I do feel like I do hear a little bit of a wheeze, but nothing like crackles or any fluid. If I were to, just gonna go underneath here and feel her abdomen, and she is seems a little bit uncomfortable. She's a little tense. She's wincing a little bit. I don't want to push too hard. It's nice and clean back there. We would feel her range of motion, so her knees. Looking for anything like laxating patellas. And also making sure that she has reflexes.
Hello.
And then one of the most important things is making sure that we get a temperature. So our 3 basic vitals are TPR, temperature, pulse, and respiratory rate. So our temperature is normal, we're at 100.4. So I would definitely bring all of these findings to the doctor and ask them for what they would suggest. Anesthesia-wise, a class of anesthesia, I would probably put her around a 3 or a 4. Just because of her heart disease, she is being treated, but there would be some anesthetic risk for her, especially because she is a geriatric patient.
But yeah, otherwise you look good.
So I have Chloe here. She's going to be helping me show how to take a blood draw from a jugular vein. My assistant here is going to be holding Chloe's head straight out, pulling her head out. While I occlude the vein, I'm going to be occluding the left side of the jugular vein with my left hand because I am right-handed. So hold her out, good girl. And I'm just going to I have a little gauze here with alcohol on it. I'm just going to be wiping here, just to part the fur. Okay, good job. And also make my area clean. Then using a 3 ml syringe with a 20 gauge needle, going to poke parallel to the vein. Okay. So since my patient did move, I pulled out my needle. I did not want to harm the patient in any way while she moved. We did get some blood. We're going to let her relax though for a minute while I hold this off. It's not really bleeding, but I do want to just hold off the vein, make sure that she doesn't, that it doesn't bruise or anything. So right now I'm going to demonstrate how to take blood from a lateral saphenous vein of a canine. So the vein comes up this way. Right now I have my assistant holding. I'm holding the head and occluding the vein behind here, tight, with a tight fist. So I'm just going to spray some alcohol, use a vacutainer, make sure my bevel is up, stabilize the vein. And then use the red top first, which is going to be our serum separator tube. And then our purple top, which is our whole blood, or lavender top. Give it a little rock. Going to take out my needle. My assistant is going to hold off pressure there, stop occluding the vein, and that is how you take blood from a lateral saphenous vein. Right now I'm going to demonstrate how to take blood from the cephalic vein of a canine. So I have my assistant here is occluding the vein, the cephalic vein, by putting pressure and giving it a little roll. She's also holding her head. I'll spray a little alcohol here, and then use my vacutainer. See the vein, so we have the accessory here, and then this is the cephalic vein. Just go straight in. And now I'm only collecting 2 red top tubes right now because we're sending out a titer. So what happened? There we go. What happened? There we go. Okay. Just had to adjust a little bit. There we go. We have a nice good flow.
I'm not gonna cut off.
And that is how you take blood from a cephalic vein. So the first thing we're going to do is start with her face. So we'll look at her eyes. And we're looking just for like any, there's no redness or any discharge. Her pupils are reacting normally. You can look at her nasal cavity here with this. I can also go into her ears. With my otoscope. Which are, you know, from the outside I see that they're not very inflamed. There's not a lot of discharge or anything. Not really a lot of wax. On the inside they look okay. They're nice, a normal color. They're not very red. The next thing that we would normally do is do a complete oral exam, so checking her teeth, making sure that we don't see any overt masses or possibly any indications of periodontal disease. I can try with some tongue depeshes, however, we may decide that this is something that we do maybe if after she's pre-medded to get a better look at her. So let me see real bad. Okay, good. So I can see, I can see her canine and her molars. Oh, good. Okay, that's a nice hiss. Do that one more time. And she is a younger patient, so I don't really expect to see a lot of tartar or anything like that. Now we can turn her around. Okay, baby. I'm going to, feel her lymph nodes, make sure that everything feels nice and normal. Really look at her coat. Generally, her fur is nice and uniform, and I don't see any bald spots. Can check her heart rate. So when I'm checking her heart rate, I'm making sure to escalate the left side, the right side, as well as kind of the sternum here. And while I'm there, I'm also listening for the lungs. She does give you a little difficulty because she's growling. So when she's growling, it's amplifying in your ears. So, I can tell you right now that she doesn't have any heart murmur or any obvious heart murmur. Her heart rate is very fast because she's stressed. Her lungs sound clear. Now we'll continue going back down. So we want to, as long as she allows, feel her abdomen, make sure we don't feel any overt masses. that her bladder is small enough, small enough for surgery, or if you have to express it before surgery. That her intestines feel nice. We'll do a rectal exam. Looking again to make sure that there's no overt masses. Is there any stool or anything present that we can check on? As well as, which I don't think she's going to allow right now, but you would also feel their range of motion. So like I said, normally we would feel for their range of motion. Again, in some cases you're unable to do it based off of the temperament of the patient, and that's okay. It's something that you can always feel after they're pre-medded or maybe during anesthesia. The next step that we would do is we would get some preoperative blood work. So that would include your most basic things would be your blood glucose, your BUN, which is your blood urine nitrogen, which is a kidney value. You want to make sure that the kidneys are able to remove waste function as optimally as possible, especially if they're going under anesthesia. The next thing would be something like an ALT, which is the alanine aminotransferase enzyme. That is usually a just kind of general screening enzyme for your liver, and kind of goes over just any basic hepatic function. You would also check a PCV, which was your red blood cells production. And if you were to find any abnormalities, you would do kind of more tests. So if we do, maybe this patient has been experiencing some diarrhea, would we get a fecal test? We would send that out to the lab, make sure that we don't have any overt parasites. If it is something like, this feline here, do we have any history of a feline leukemia or feline infectious FIV test? We would try to run that as well to make sure just that we've covered all our bases. But this patient, after physical exam, seems healthy enough for her surgery. Anesthesia-wise, we would put her under a class 1. She doesn't have anything overt going on. We would just have to double check her blood work and make sure that everything is okay. So today I'm going to be taking blood from jugular vein of a cat. This cat has been sedated a little bit just so we can get a better sample. I have been occluding the vein here, and because I'm right-handed, I'm occluding with my left hand, and I'm going to be taking it from the left side of the cat. So this is our vein right here. I have some alcohol here that I'm just going to wipe a little bit, and then using a 20 gauge needle on a 3 ml syringe. I'm going to come at this vein parallel, just very easily. This cat has been given some sedation, so the vein is a little bit, there we go. So right now I'm going to demonstrate how to take blood from the median saphenous vein of a cat. I'm going to, while my assistant here is occluding the vein while also holding off the right lateral inclemency, I'm going to use my vacuum tuner and go in at a parallel angle to the vein. And now of my 3 tubes here, I'm going to start with my serum separator tube, my red top. And since this cat is pretty sick, I believe the vacutainer has is a little bit too much pressure for the vein, so the flow is a little slow, but we are still in the vein, so I don't want to adjust anything. Now, not have to get the green top. fill it up, and that is how we get blood on a cat. So today Ishi here is going to help me demonstrate how to get blood from cephalic vein. I'm going to use a vacutainer set here, and these are my two tubes. This is my plasma tube and my whole blood tube. Cephalic vein of the cat is in the front arms. So I've already wet it with a little alcohol. Lisa here is occluding the vein by holding pressure by the elbow. I'm just going to wet with a little alcohol here. Here's the vein here. Making sure my bevel is up, just go in parallel. I do have a flash, so now I'm going to start with my plasma tube first. Fire rocket as we're getting the blood. And then move to my whole blood tube. Making sure again to keep the arm still and my needle still. The tools to rock these as well. And now I'm going to remove the vein. She's letting out pressure, and I'm just going to hold pressure here. And that's how we get blood from the cephalic vein of a cat in the hospital. We have two different calculators that have been calculated and pre-made with our doctors and our staff here that we can go off of the weight of the patient. It will break it down into pounds and kilograms, and it'll give us kind of our doses for us. We of course always double check this, but this kind of is an easy breakdown for us. We usually split this up into feline and canine. So for example, if I were to have a 10-pound feline and canine, these are the typical medications that we would give before basic surgeries or routine surgeries. So we give an anti-nausea medication before we give any pre-medication. Our feline drugs are usually buprenorphine and Domitor, so a pain medication and a sedative. Very rarely do we give atropine, but there's, it's the doses there just in case. And then we will actually intubate them with propofol. And then the same for our canines. We'll give Serenia, which is an anti-nausea medication beforehand, and then we give them butorphanol and Domitor. Domitor again for the sedative purposes, and butorphanol for the pain as well as the side effect of having a little bit of a sedative. And then again for them, we induce them with propofol and then isoflurane. So these are just our typical pre-anesthetic protocols that we have at this hospital. So today I'm going to be completing a log in our controlled substance book. This book itself has a number of different medications that we have, or controlled substances: buprenorphine, butorphanol, ketamine, midazolam, euthanol, tilazol, tramadol, phenobarbital, and a couple of other ones. So for right now, I'm going to be doing the nighttime balance, which we do every day, looking for any errors or mistakes or anything lost. To do this, I'm going to use buprenorphine as my example, and you can see here that I have kind of a number of lines to fill out. So I have to fill out the time it was ordered, the reason why we've used it, the type of medication it was, which bottle number it is. This is how we keep track of which bottle we have opened, the amount used, the amount added, the amount used, the doctor to sign it, who's prescribed it, the total balance that we get today, and then the initials of whoever has logged it. So for right now, there's only going to be, there's a couple things that we won't fill out so let me start by logging this. Making sure to get kind of every drip. I don't want to lose any by doing this, though you may lose some in the hub. So I'm supposed to have 2.8, and I have about 2.7, so that's a 0.1 loss. Let's see, there's a little bit more in here. Yes, I have about 2.7. So there is a 0.1 loss here, however, we did use this today, and at times there is a loss of medication from transfer from syringe to patient, and especially there is some loss if you go to balance it and you don't get it all out. So I'm going to put in my date. The client is just going to be the nighttime balance. The time ordered is 7/11. Our drug is buprenorphine or buprenorphine. Our bottle is 1 to 5. We haven't added any. We haven't administered any, and I don't have to have a doctor sign this because there's nothing that's prescribed. And the amount that I have here is 2.7 mLs, and I will put my initials. And now that is filled out. That is how we complete logs in our drug log book. So this is our anesthesia machine. It is a Cardell Touch. We have a number of different leads here that we use to monitor patients during surgery. Starting with just kind of our leads here, we have our ECG leads. These get hooked up to monitor heart rates and to include a waveform, which would be here, which is kind of messy because I'm playing with the leads. The next thing coming down is our SpO2 or pulse oximeter. That is this one here. This can be placed on the tongue or the ear and is used as a measurement for the oxygenation of the patient through the blood, which usually you want that number to be above 98, 95 to 100, but ideally above 98 or 100. Our next lead here is what we use to monitor our end-tidal CO2, so the amount of carbon dioxide expelled from the patient in their breath. A good way to know if the patient is breathing is with this. You would see this here, either rapid breaths or nice breaths. So for example, you would not see a value there if the patient is not breathing on their own because they're not expelling any carbon dioxide. One of our other leads here is our blood pressure. So this pushes air into a blood pressure cuff, which we have in these bags here. A number of different sizes. We'll pull out this one. So again, blood pressure cuff that's filled with air. We put this on patients' limbs to monitor their diastolic and their systolic pressures. Every patient is measured around their limb to make sure that we give them the appropriate blood pressure cuff. If the wrong size blood pressure cuff is placed on a patient, it can give us an abnormal number, or maybe say it's too high or too low than what blood pressure actually is, this value would show up on this screen here. So we have our EKG or ECG leads, our SpO2, our pulse oximeter, our end-tidal CO2, our blood pressure, and then one of the last leads that we place is our oral thermometer. We place this when a patient is intubated in their through their esophagus. Down pretty far, and that'll give us the internal temperature of the patient. One lead that we don't have here are esophageal stethoscopes. These are placed, it's a tube that's placed down the esophagus as well as an oral thermometer, and has earpieces at the end so that you can hear a rhythm or a heartbeat and not be kind of in the way of surgery if you have to get a manual heart rate. So we don't have those leads here to explain or demonstrate. Moving down here, we have our isoflurane vaporizer. This literally takes the liquid iso that we use, or isoflurane that we use, and vaporize it into the anesthetic gas. Moving on over here is our oxygen. So this is in liters. When we turn this on, depending on the size of the patient, is the amount of oxygen in liters that they get. So if they get a 1 liter versus a 2 liter versus other. This is our oxygen valve here, which fills the rebreather bag. Here is our oxygen line. So this is an out and in tube. We do not have two separate tubes. When we hook this onto an endotracheal tube, they get oxygen in and they can breathe out, and it'll go out through the outside of the line. Here we have our pressure valve. Usually when we're giving breaths, we want to make sure that the pressure valve does not go higher than 10. This is our pop-off valve here, which is a little button here. If we do have to give breaths, or are checking the machine, we can hold this button here for easy access. Or with this knob here, we can completely close the machine and this will send everything to the patient. We do want to make sure that when we're in surgery, if we're done monitoring, or if we're done checking our anesthesia machine, that this valve remains completely open. Otherwise, the patient will not be able to expel gases correctly. This here holds our soda lime for our anesthesia. This almost acts like a filter, and these white soda lime beads here, or rocks here, will turn purple as it filters out the anesthetic gas. Here's our rebreather bag. Again, this almost acts like an external lung for patients. So we can give them breaths through here. We can see how they're breathing through it. We have, now here, this is our oxygen supply. We have this plugged in. This comes in through our system. And this red tube here is our scavenging system. So any isoflurane or any anesthetic gas that comes out of the patient or out of the system goes out through the scavenging system, which goes outside, through the side of the building out into the exposed air, and we check the scavenging system once or twice a year. Other things that are presented on a patient, can you get me ET tubes? Are endotracheal tubes. Those are literal rubber tubes that are placed inside the patient's trachea to help them breathe. We can monitor their breathing better, and also to stop them if they happen to vomit during surgery. It's a lot safer, it keeps their trachea safe. So this would be placed in a patient's trachea, in their mouth. This here is used to inflate the tube down here to make a nice fit. And then we hook up all of our instruments, or our oxygen instruments, onto here so that we can literally monitor their breath through this tube. Other parts of our anesthesia machine, or when we have patients under anesthesia, are our rebreathing bag. So this is used generally in our smaller patients, patients that would ideally have a better result under anesthesia from using a system that has less weight on their lungs, so it helps their lung capacity, and helps them expire gases easier. It leaves a lot of less dead space. So the way this works is that this is the system. The endotracheal tube would be put here. This is our rebreathing bag. On the side here, this acts as our pop-off valve. And then these tubes here, one of them this tube here is hooked up to our isoflurane, and this red tube here is hooked up to our scavenging system. So it leaves, like I said, a lot of easier for smaller patients to breathe under anesthesia. The other things that I wanted to talk about are our oxygen masks. If we do have a patient that comes in that would benefit from any oxygen, you can use these as well for inhalant anesthetics. If you have to get a patient under anesthesia, then they're not doing well with either their pre-meds or their IV intubation, IV inductions. Generally, we don't use these here for inhalants. We will use them if we have a patient that needs oxygen. So these are sized appropriately to go over their snout. And the last thing that we have here is an induction chamber. This is used for generally like exotics like mice or rabbits, and is a chamber that can literally be filled with anesthetic gas when hooked up again to the system. So one end would be hooked up to the anesthesia and the oxygen, the other end would be hooked up to the scavenging system. And this is a sealed container that would be that you would fill with anesthetic gas. Once the patient is asleep, we would take them out. But again, this is something also that we generally don't use here at the practice. We have it just in case, but we find that these methods of anesthesia aren't as safe as having an endotracheal tube placed, so we try to have all of our patients intubated for anesthesia. So we're going to do a leak test on our anesthesia machine. There are two different ways of doing this, or two different steps that you need to do when you're testing leaks. The first thing that we're going to do is test the entire machine itself. So we've taken off the rebreather bag that would normally go here. I've closed this valve so that all of the oxygen stays in this machine. What I'm going to do is put the oxygen to 1 liter. I'm going to hold off this tube here. This is where the oxygen would be going in, and our rebreather bag is going to need to be held here, so you can hold that. What we do is hold this until pressure builds till it's between the 30 and the 40. Once the pressure has been built, we turn off oxygen and make sure that the pressure stays. So you can see right now the pressure is not staying, which is indicative of a leak in our system. Either that or it can be human error, so we can always do this again and double check, but that's usually how we perform leaks in our system. Go. So Bailey here is going to help me demonstrate how to put in an IV catheter in her cephalic vein. We're using her right front arm. Her cephalic vein is her primary vein in canine and feline's front arms. So the first thing we do is we shave the area so that we can see, number one, see the vein better, but also so that we can clear away any debris and keep the area as clean or as sterile as possible. So once we shave, we will also clean the area, try to keep it as, not sterile, but as surgically clean as possible. So I do that by wiping it with chlorhexidine and alcohol, and then we place the catheter. So we'll start with our little shave here. Good job. Good job, clean it off. Okay. So now, my technician here is holding the dog so that we're both protected, holding her neck, but also occluding the vein. And she's doing that by putting pressure on the vein and giving it a little twist. I start with the inside with my Chlorohex, and I start on the inside and I just kind of give a little circle and I work my way out. And then alcohol next. Now that the area is clean, I'm going to put in a 22 gauge catheter, and I'm also making sure that my bevel is up and going parallel to the vein, making sure I get a flash, and pushing it in. I'm also now going to hold off the vein. She's now let up pressure, and I was holding off the vein, not next to where the catheter is exactly, but just enough to make it so that our dog doesn't bleed everywhere. Now I'm placing our tape. Now this first piece of tape is one of the most important pieces. This really holds the catheter in place. It really keeps everything nice and stationary. Start with our 1/2 inch tape.
Okay.
A little notch in our tape. Move on to our 1 inch tape. Put that underneath our catheter now. Start wrapping it up the leg. Not making it too tight, but just tight enough to hold it in place. And I'm also, as I'm wrapping it up the leg, I am going about 50% from each layer that I've started. Now that I have this in, I want to put my T-connector in. This helps technicians have better access to the IV, gives us a little bit of room to work with. So I have a saline flush here, and I'm just pushing it through there so we don't have any air bubbles. Now I'm going to hold the IV here, kind of occlude it a little bit. Put a piece of gauze underneath just so we keep it nice and clean. Occlude my vein, take off my stopper. And now that we know we're in, now you don't like to get a lot of blood down there because it can breed bacteria, and you want to keep the site as clean as possible. I'm just gonna wipe this a little bit here. You're so brave. You're so brave. down here.
It's okay. It's okay.
Holds our T connector in, and now our final piece of tape here.
It's okay, Val.
It's okay, we have all these tapes and it holds it in place. Good job.
Our final piece of tape here that really just kind of holds everything together. And like I said, again, you don't want to have a lot of blood because it can breed bacteria by your IV site. Clean this up a little bit. You also want to make sure that this is nice and dry. So now that our tape is in place, I'm just going to flush this IV while we're clamped here, just so that we don't have any blood clots. I also can double check that it's in. I feel it up here. I can definitely feel it. You can also hear it kind of push through the vein there. Put my cap on. And the last step I'm going to do is just kind of cover this with some fat wrap. And that is how you put in a IV in a cephalic vein of a dog. So right now I'm going to demonstrate how to put in a saphenous catheter. Saphenous veins are located in the hind limbs of canines and felines. The first step in putting in any catheter is shaving the area and making sure that it is as clean as possible. We do that by wiping it with 2 agents, borax and alcohol. I'm going to first start by shaving. So wiping with our Chlorohex and then our alcohol. Christina here is occluding the vein up by the thigh. And then when I grip this, I'm going to kind of pull the skin a little bit taut. See my vein, making sure my bevel is up. Insert the catheter, feed the catheter itself. She is not occluding the vein anymore, she's just holding out the leg for me. I did hold pressure where I had administered the catheter, but because we're a larger breed dog and our blood pressure is so fast, that's why we were bleeding so much. We do want to make sure that we clean up any blood that is left there though, because it can breed bacteria. I start by placing the tape, and it is a little bit harder in hind limb catheters, so it's all about placement and positioning. Start with my first piece of tape. On to my second piece here. And when I go with my tape, I'm going up the leg about 50% up each layer of tape. Now I'm going to try to hold off the vein again. When I apply the T connector. Okay, the T connector just ensures us that we have easy access to the vein itself and that we don't have to fiddle with the catheter too much. Connecting, securing the T connector in place. Got a little bit now that I have a number of layers in place. I can ensure that my catheter is in.
There's a tail in my way, excuse me.
Again, just layers of tape now, just kind of going up the leg itself. Now that I know my catheter is in, could go ahead and cover this in vet wrap. For use later, but that is how we place a saphenous catheter. Otto here is going to help me demonstrate how to give sub-Q and IV injections. I have here right now just a flush of heparinized saline, just we're going to use as an example. It's 1 ml, so what I'm going to do is give him an injection down here on his left hind leg. Looking for a nice pocket of skin here, I'm going to make a tent out of. And I'm making sure to get it in the subcutaneous space, so not in the muscle layer. Hold on 1 sec, dude. Good boy. Good boy. Good job, Anders. Good job, buddy. The next thing I'm going to do is demonstrate how to give an IV injection. What we're doing right now is just occluding his vein on top while she holds. There's just about 0.25 mLs of saline in here. So I'm looking for the saphenous vein, spraying a little alcohol. And he's going to be such a good boy, right? I'm going to go in parallel, make sure my bevel is up. Once I get in the vein, and I get a flash, my assistant's going to let up pressure, and I'm just going to inject and then hold off. And that is how we give those 2 injections.
Yes.
So right now I'm going to be demonstrating how to give an IM or intramuscular injection. And we're going to pre-med this patient for a surgery that we're going to do. So this is a combination of dextromethor and butorphanol. So I'm looking for kind of along the spine a nice comfortable muscle spot here, and a good one right here. So I'm looking for that nice firm mass, not anything like sub-Q, which is very soft and squishy. I'm just gonna apply a little alcohol here, and then just go straight into the muscle. You see that the patient twitched there. So I'm going in and then in and straight back out. So I have Brooklyn here. She's going to help me demonstrate how to anesthetize a patient. I'm prepping her for surgery. She has already been, has her IV catheter placed, so we're going to just start by administering propofol via IV. I'm going to start with a small amount. Once she's nice and sleepy enough, then we'll start the actual intubation.
Right back in. Okay. Thanks, Stefano.
Working. Good. Good. I have the biopsy results. It came back as good news. It's a lipoma, which is a fatty type 2-9 mass. So
I'm just going to give her just a little bit more.
Really? Okay, great. Looking forward to this. I'll see you then. Bye-bye.
will start the actual intubation process. So I'm using my laryngoscope. Christina here is holding our patient sternally, pulling out her tongue so I can really get a good view inside her mouth.
About diabetic food or?
I put it in.
Oh,
Yes.
okay.
Work on the desert.
Okay.
A little bit more propofol.
The first day I went to Philippines.
I was like, I'm pretty sure you should.
I think in
But I'll-
English and in Italian.
I looked up, but I put it in. And then he had another question too. That cat, Allie, she's clinical or what, or you just
Wait,
learn?
She's at,
No.
oh, faint murmur, not
Okay,
clinical.
okay, that's all I wanted to know. Before I
I'll make sure I have 3 different size tubes here. I have a 5.5, a 6.5, and a 6, which should be appropriate for her size. Let's start with the 5.5. I'm using my laryngoscope and pulling down her epiglottis so that I can get into her trachea. Just putting that directly in. Okay, so we do have a little bit of a gag reflex. That's okay. Don't want to make sure you push this in too far. Oh, good job, good job. More propofol. So just make sure I get this in place and get her under anesthesia. Okay, we're going to place her just on her side here. Okay, I'm turning on my oxygen.
Sammy, Warren, what I'm with Sammy.
Make sure we're all hooked up. I have my O2 monitor here. We're going to hook up our SpO2 monitor as well. This looks at the oxygenation going through her blood. Okay. Okay, and we're going to inflate the cuff so that we can look out for any leaks and make sure it's a nice snug fit. That way, in case she regurgitates or vomits, she won't aspirate. So actually, I think we're doing that, and I will come over here and we'll check the valve for any leaks. Okay, we're just gonna fill this the breather rag with a little bit of oxygen. Hold the pop-off valve, and I'm gonna hold now. Ready? Okay. You hold. Down. Let me check one more time. And hold it. Okay. So I'm also making sure not to put too much pressure in the rebreather bag, not going higher than 10 here. And now we'll start her on anesthesia. We'll put her on a nice 2. Hook up all her other leads while we get her in a nice anesthesia plane. That way we can monitor her. Starting with our, we've already had our SpO2 lead on. We're going to do our ECG leads. That aside. Right. Left. Just get alcohol. I'm gonna offer her a little bit of a breath here. Make sure all of our leads are good. So our ECG is reading. I don't really like that waveform there, but we can see a definite heartbeat. I can see that she's taking very short or very long, deep breaths, so I'm going to help her out a little bit more there. And her SpO2, which is that 96 orange there, we want that no lower than usually 95, ideally 98 and above. But right now, we're just going under anesthesia, so that's better playing. While Christina monitors, I'm going to start shaving her out here. She is a spay, so I'm going to be shaving her abdomen. And again, while she's holding her, we're making sure not to move her endotracheal tube. Make sure that we get as close to the skin as possible without giving her a laser burn or nicking her. just move her the umbilicus here so I can just move her where the doctor is. Okay, so I'm going to get a very close cut here. Smiling. Now that we finished shaving out here, we're going to move her into the surgery suite. As we want to keep the surgery suite as clean and as sterile as possible, we've kept these lab coats on so that we don't transfer any hair or any extra dirt that we need to. So we're just going to take her off the isoflurane for a moment, undo all of her leads, and carry her into the surgery suite.
He said the room doesn't smell like shit anymore.
Okay. Now, before I turned off the anesthesia, before I turn off the oxygen, I'm making sure to give her a little breath. Removing the tube and now turning off the oxygen. And now we will very carefully move her into the surgery suite. The reason we're doing this on a gurney and a stretcher is just to keep her as still as possible because we don't want to damage her trachea with the endotracheal tube in there. And we'll also make sure you get rid of any extra hair. And we'll also take off our lab coats.
Good, how Billy?
I'll put her here.
Okay.
And now we're just going to transfer her very carefully to the actual surgery table. So I'm holding onto her neck, keeping her neck very still, transferring her this way. Now again, we're going to follow the same procedure that we did outside. Turn on our oxygen.
Let me just check.
Hooked up to oxygen, monitor her breathing as soon as possible.
Yeah, we didn't actually send out a stool sample.
Put our SpO2 on as soon as possible so we can monitor her oxygenation. We'll put her on a little bit of a lower isoflurane clean. Christina is already replacing the leads, the ECG leads.
But if it continues, you should definitely check.
So again, black on left, right on right, red on the hind left.
Alright. You know, the best, as long as she's eating, you know.
One of the last pieces of information we need is blood pressure.
That's my main concern.
We'll find that as well.
Okay. No problem, keep us posted. Have a good one, bye-bye.
And we're just going to get her into position now. So if you can hold her back legs for me. I'm going to put her on. Here we go. Also going to put a temperature probe, esophageal temperature probe in. pressure. Good for just a little help in breathing here. And then the final step of prepping her for surgery before the doctor comes in is making sure our patient is scrubbed, sterilely clean, as surgically clean as possible. So I'm starting with a chlorhexidine scrub. Starting from the inside and working my way out. Fix that in a minute. I'm going to do that for a minimum of 3 times. The reason you start from the inside and work your way out is so that any debris that is stuck in the middle or any dirt is pushed out to the outer edges, because the middle of this dog's abdomen is going to be where the surgeon cuts. I'm going to do one more. Okay. Let me put alcohol. So right now I'm going to demonstrate how to prepare for, to get ready to be a sterile technician by completely scrubbing and gowning into surgery. The scrubs that I'm wearing, I have my shirt tucked into my pants. I already have my bouffant cap on and my mask on. The first thing that we're going to do is wash our hands, and it is a process. So when you're washing your hands, you start with an antibacterial soap, and then go on to the betadine scrub that we have here. So whenever I'm washing my hands, I am starting with just a basic scrub, antibacterial soap. Making sure to always rinse from the fingertips down to my elbows. And then the next step is to use the betadine scrub that we have here. It also comes with a like a nail pick, so I can use this to clean and get underneath my nails, clean any debris or any kind of dirt that's stuck under there. I can use it for my cuticles, and this is helpful. This is helpful if, say, the glove that I'm using, God forbid, rips or tears, and then I know that at least there's no extra dirt or anything. So we start with this, and then we move on to the actual scrub itself. So every surface, the surface of your hand has 4 sides, and we're going to do this a 10 times scrub on each surface. So it would be, for example, starting with the left side of my left hand here. I would count 10 times on the left side, 10 times with the other fingers on the palm, 10 times here, and also making sure to get the webbing as well. Starting with the same side on this hand. Okay, go up my arm now. making sure to keep my hands above my waist. And again, when I rinse, I can rinsing down from my fingertips to my elbows. A little bit more stuck in my fingers. Okay. Now that I'm surgically clean, we're gonna want to put on our gown and our gloves. So I'm just, Ray, do you mind opening my pack for me? Like normal, like for piano. So, what Rayanne is doing right now is she's opening the first layer of the sterile gown. There are 2 layers in every pack. So she's making sure to open the first layer, and now I can go ahead and open the second layer. As this is the most sterile part. The pack usually comes with a hand towel, so I can start with one hand, make sure that my hands are very dry. Use the other side for my other hand. Toss that down. And now I can open my pack. Now I'm going to accordion open my pack here. Make sure not to touch any surface. And these are usually wrapped inside out so that you can just very carefully put it on like so. And I'm going to leave my fingers in here because we're going to perform a closed glove technique, but I can touch my seal. Can you open my gloves for me? So now again, because I'm sterile, and the outside of the package isn't sterile, Jordan is going to place the gloves onto my sterile field so that I can open them. Actually, if you could take them out. Thank you. Okay. So now again, I'm making sure that I'm far away from the surface. I can start by opening my sterile glove package here. Still not touching with my fingers, but touching with the cup. I'm going to do my right hand first. I'm going to use my left hand to grab onto this. And carefully my fingers through over the gown. Leave that just like that now. And now with this hand, I can touch the inside surface here, because this is a sterile field. Do the same thing.
So I didn't give her the surrounding on my because I gave her the dry food. She wasn't salivating. She wasn't letting her lips. And she ate it right away. Not finished it, but she started picking immediately. Like immediately. So I was like, it's not easy. I have to do it between my knees.
Pull this all the way down, and now with this hand, I can go underneath and pull this all the way down. Keep my hands above my waist, because everything considered kind of below the waist. So now that I am sterile, I have to make sure that I don't lower my hands below my waist, or touch anything that isn't sterile. So this table has been set as a sterile field. In this second layer here is our instruments. I'm going to start by draping our patient here. Should unfold. In such a way that I don't want to touch any other surface, and I want to just make sure to place it just directly over our area. Okay. Prepping the instruments for the surgeon includes putting the scalpel blade on the scalpel, and getting any other instruments that he may require, so the nuts and bone scissors, the towel clamps, as well as the forceps. Dr. Maleo is present with us here today. He is going to be performing this guide. Yeah, so I guess we can begin.
Can I go in the sidebar? Could we have the lights, please, Christina? Start by placing towel clamps at the top of the wrist, or?
No.
I'll take a scalpel, please. And thank you. Cutting. Forceps, nuts and bone scissors, please.
At this hospital, we are able to be a part of many different procedures, including spays, neuters, dog cats, gallbladder surgeries, ACL repairs, cystotomies. Dr. Maleo is present in most, if not all, of these procedures with us. If you can just specify that I have actually been in these procedures.
Oh, absolutely. Veronica's often one of our main helper assistants during surgical procedures, and she's progressing nicely. Once I cut here, then we'll have the blot. And just tying off the uterine body now. It's tied.
Of the duties of the sterile technician during surgery, they include helping reduce or helping improve visibility by blotting if there's any blood, keeping the skin as moist as possible, monitoring anesthesia.
Can you just blunt the stump for me once? Okay. Good, there's no bleeding. Okay. Let's take this real monochrome. Just blot that one more time, please. Good. Now we'll just close the.
So right now I'm going to demonstrate how to perform CPR on a patient that if it goes into cardiac pulmonary arrest mid-procedure. For right now, I don't have a dummy and I don't have a patient to practice on, so we're going to demonstrate this by using a towel. I'm going to, I've hooked up some ECG leads. I have an SpO2 monitor hooked up. I do have a ET tube or an intratracheal tube hooked up to oxygen. So in this case, it would be the patient is already hooked up to all these instruments while it's under anesthesia during this procedure. We would, at that point, if it does go into arrest, we would put it in right lateral recumbency or lateral recumbency, and the first thing we would do is start compressions as soon as possible. At that point, we're kind of not looking at our ECG leads because they might not be as accurate because we don't know what's going on with the heart right now. To start CPR, you need at least 2 team members, one doing the chest compressions and one giving breaths or respiration. When you do this in intervals of 2 minutes so as to not fatigue your staff and also to maximize the amount of compressions that you're able to give. So for example, if my patient was about a 15-pound cat or dog, I would be doing about 120 compressions per minute with the rate of about 10 breaths per minute. So for example, we would start, I'm climbing up on a stool so that I can maximize my strength here, and we'll start on compressions now. So now I'm thinking in my head, there's a song in particular that you can think of, Staying Alive, which if you think of the chorus where it would be staying alive, you're going to do it at that speed. And you want to make sure that your compressions are about 30 to 50%, and you're giving the entire thoracic cavity time to lift up. You're not just kind of pushing down and then only releasing a little bit. So if you were to do this for 2 full minutes, you would get very tired very easily. So you want to make sure that you're communicating with your staff as well, that if you don't reach the full 2 minutes, you switch out. So for example, I am pushing on the ventral portion of the thoracic cavity. I am thinking in my head how fast I'm going and trying to monitor as well the time. So I'm already at a minute, and if I were to be doing this on a live patient, I can say that I'm already very tired. I'm also on my stool here, so I can maximize my effort here. So at this point, I would say we're going to switch. I come over here, we would do this as fast as possible, and now my other staff member would start compressions while I am giving breaths. So it's more of just keeping track of what everyone is doing. You would have a timer, somebody doing compressions, and somebody giving breaths, hopefully to get our patient back. At that point, there's more advanced CPR, which would include giving medications that the doctor would then tell you to administer. But that's how we perform basic life support. So starting with our leads on our anesthesia machine, we make sure that every lead is wiped down from probe all the way down to their wire in case there's any bodily fluids or organic matter on it. All of our surfaces get cleaned. We make sure we flush our anesthesia system. Every surface gets wiped down with a Chlorhex or Rescue solution, Rescue being the primary cleaner and disinfectant that we use in this hospital. It's a accelerated hydrogen peroxide mix. The other thing that I feel is overlooked a lot, or can be overlooked a lot, is we also make sure to wipe any or all of lighting surfaces if the surgical technician has to adjust for the doctor. Because we try not to shave in the surgical suite, we try to shave outside the surgical suite to maintain sterility and cleanliness. There usually is minimal hair, however, we still will vacuum the entire surgical suite after that every surface has been wiped and cleaned. And mop with a separate mop that doesn't touch the rest of the hospital, that has a little bit more of a mixture of bleach and water than the rest of the hospital was, and that's again to just maintain sterility or cleanliness in this case. The waste bucket here is cleaned and cleaned with alcohol, dumped and cleaned with alcohol. The surface of our sharps container is cleaned with alcohol as well. And leads that we use for every patient get put through the wash. so that we just have no contamination anywhere, just in case. And then, so right now I'm going to demonstrate how we clean and wrap our packs here. I just have a couple of instruments in here. Right now what we're doing is it's called the pre-soaking stage, where they've come out of surgery, that maybe they have some organic matter like blood and tissue, and we want them to soak before that dries on the instruments, and then it becomes harder to clean. After they're pre-soaked, we leave them in a Chlorhex basin here, and I have a soft bristle brush here, and I'm just kind of scrubbing off the instrument itself, making sure that there's nothing left on it, any blood or fingerprints, especially in things like this needle driver. I'm getting not only the handle itself and the top, but also I'm opening and closing and making sure to get in the bridge there, or in the joints. And usually if any of the instruments have grooves, like this forceps has some grooves here, just making sure I get kind of all in there. Then we usually leave them here to dry. Once they are dry, we take them and we bring them to our ultrasonic cleaner, which is our second step of the cleaning process for instruments. So we can come over here. And I'm going to place this in the ultrasonic cleaner. Now this has it's a mixture of distilled water and an enzymatic solution that kind of acts as scrubbing bubbles. So when I turn this on, I'm usually going to let it run between 3 and 6 minutes. And what happens is it's ultrasonic, so there are sound waves that are very, very high pitched that almost you can't hear. And they create very, very small bubbles that almost act as a scrubbing agent in the solution itself, aside the fact that it does have some kind of detergent-like properties in there. So once I start this, it's going to get a little loud. Once these are finished in here, we take them out, and I prepare, we let them out, we let them dry, and then I prepare a lubricant spray. And we put this on this just to maintain our instruments, keep them longer. So I'll start this. So now I'm going to be wrapping this gown here. When you're wrapping gowns, you want to make sure that you do them inside out, so that when the doctor puts it on, when he or she unravels it, the first thing that they can do is just put their arms right on it. So usually what I do is make sure my sleeves are right side out, fold in, make sure all my lines are right, and then fold back out. Take this outside layer and move in so that it's kind of an accordion-like. Flip over, fix this a little bit, do the same thing. So now we have a nice thin gown, and then we're gonna accordion it from the bottom to the top. Leaving our strings out so that when the doctor grabs it, they can just grab the strings. The other thing that we're going to put in here is a hand towel, so that the doctor when she's finished washing her hands, can dry her hands. I'm also going to put a sterile indicator strip in here. This will change color after it has been sterilized, and give us the indication that the pack is indeed sterile. If the doctor were to open this and notice that there's no color change, then we would have to double check our sterilization. When we go to actually wrap a pack, I have 2 layers here, so I'm going to start with the inside layer and really pull on this. And essentially what I'm doing is pulling all 4 corners in and folding them back and forth on each other, almost like I'm creating an envelope. So I start with the bottom, go to the sides, again to the sides. And now we're on top. And with this last layer, I am going as hard as I can and folding it into the previous layers that I've made here, while also kind of leaving a little tabby here. And what this does is create almost like an envelope where if I were to pull this, the whole pack would open and you wouldn't have to touch any of the layers, and it gives you a sterile feel. So now I'm going to do the same thing with a second drape. And this is, again, to keep a layer of sterility with our packs. Same thing here. Maintained my tightness and left a little tab here. The last thing I'm going to do is get my sterile indicator tape. And place this on the pack itself. Over where my envelope has come. So I'm not going to go this way, I'm going to go this way, so it kind of holds the pack as well. Holds it tight, leave a little tab so that it doesn't rip our pack once we're done with it. And now write what is in this pack. So this is a surgery gown, the date that it was made, as well as my initials so that you know who has made it. And this tape now will also change color, giving us the indication that once this pack is out of the autoclave, it has been sterile, we can put this away. The outside layer will not be sterile, but the inside layers will be sterile. And that's how we wrap a surgical gown. So now that our instruments have come out of the ultrasonic cleaner, we have lubricated them and let them air dry. We place them in our pack, and we're ready to wrap the pack. The last thing that we do in our pack is place a sterile indicator strip like we had placed in the surgery gown pack. So for example, this is a not used sterile indicator strip, and this one has been used, so you can see the difference that this was once a sterile pack. So we'll get rid of that. Place a fresh one in here. We'll also place a hand towel and start wrapping. So we wrap with the same method that we have for the surgery gown. Just bigger drapes. So I start by using the bottom, pulling as tight as I can. Again, folding it onto itself a couple times. Going to one side. Other side. And because these drapes are squares and the packs are rectangles, sometimes they don't fit exactly perfectly, so you kind of just have to fold it a little bit. Again, folding it in on itself, leaving out that little tabby there. So like with the surgery gown, we've created almost a layer of sterility there, where the doctor can now only touch this layer and his instruments will remain sterile. Typically want this to be very tight. So now the same thing, I'm going to use my sterile indicator tape. Put it around my pack. This is an OVH pack. I'm going to put my initials and the date. And now we can be ready to put these in the autoclave. So our last layer of sterilization, our last layer of cleaning is the autoclave. This is really where the sterilization happens. To pack this, you want to make sure you don't overpack it, because then either the instruments will, I guess, feign sterility, but they won't actually be sterile because the bacteria that won't be able to vent out, or the heat won't be able to vent out the steam. So they have these grates here, and what I'm going to do is just kind of place this OVH pack in here by itself for now. That way the steam can come up and then come out. In this machine is distilled water because bacteria can brew in regular tap water. So we want to make sure we have distilled water in here. And the way this machine works is by electricity heats the distilled water and creates steam. The steam creates pressure. And with the combination of heating to about 250 degrees Fahrenheit and the pressure, it is able to clear any bacteria that is in there. So if I were to start my packs, I can see that this is going to reach 250 degrees. It's going to take about 30 minutes to probably reach that temperature. And then once it reaches that temperature, it is the door itself will kind of open a little bit and it will steam out and vent out itself. So if I were to start this, this is now filling the chamber with steam. It does take some time, but this will let us know once we're all done in about, I think total about an hour. But that is how we sterilize our instruments here. I'm going to be removing Lulu's sutures. She was spayed on the 29th of March, so it's been about 2 weeks, which is usually our time, 10 to 14 days of leaving the sutures in before we check them. If you come in here, the owner did tell us that they haven't been keeping the cone on, so there is some sutures that have been misplaced. The incision site looks really well. There's a little crusting here, which happens, can be from just a little suture reaction, or just the skin meeting. So I'm going to take my sterile suture scissors and go underneath the knot and just do a little clip here with the hook and remove that one. Again, so good. And if this was very red or the skin didn't meet up, then we would be advising a doctor, asking a doctor what the next plan of action was if we were to remove the sutures or not. Okay. So I'm also just going to Chlorhex gauze on here. But this is healing well, and that's how you remove sutures.